patient receives a sedative medication like a narcotic or an anesthetic, that medication affects their breathing by slowing it down, risking even a respiratory failure. And this matters to the patient because the patient's heart and brain does not get enough oxygen, leading to a heart attack or a stroke or even death. And this happens because current monitors are unable to detect dynamic changes of breathing early. They're indirect and late monitors and only provide qualitative information so our detection is delayed. Airflow is the only device designed to avert respiratory deterioration by identifying these life-threatening breathing changes early. Complications increase cost. We all know that. The US alone has a $54 billion healthcare cost due to respiratory complications annually. And when you look at all healthcare costs, these complications are the fifth leading reason for those expenses. $2.6 billion per year are added because 1 in 8 elective surgeries have post-surgical respiratory failure, leading to an increase in mortality in that group, adding more days to their hospital stay. And it accounts for an over $50,000 healthcare cost difference between the ones who do and the ones who do not have a complication. Among all hospital deaths across the United States, 66% are reported to be due to respiratory failure as their leading cause of death. So you may ask, how is that possible? Well, deterioration is not visible to us early. It doesn't matter how smart you are. This is what we see. Here is a monitor of a patient X and a patient Y. Both look the same. Both show the same indirect secondary measurements, but one is actually obstructing and struggling, and the other one is fine. Can you see the difference? I can't, and I'm supposed to be the airway expert, but patient Y will soon decompensate. Wouldn't it be better if we could see and intervene when the numbers still look good and the patient is still safe? We just don't know when and how much the patient's breathing is going to change, because we're relying on outdated technology. Look, we're using pulse oximetry probes, so the little stickers on your finger. And sometimes we collect gas from your nostrils. We call that capnography. Both haven't changed in 40 years. Those devices are not respiratory monitors. They measure only secondary, downstream parameters of breathing, which means that the detection of your breathing complication is primarily dependent on the subjective assessment, the experience, the expertise, and the bias of that healthcare provider. And that can vary. Very counterintuitively, the patient needs to have a breathing complication first, deteriorate massively first before the monitor's alarm. We're reacting instead of proactively preventing damage. Well, Airflow can see and can inform you when and how much a patient's breathing is changing by providing real-time, continuous, quantitative, and objective information of your breathing. Everyone sees the same. No matter the education level, no more guesswork. Our technology consists of a disposable neck patch with a reusable sensor that applies ultrasonic waves to acquire airflow data. We process the data, and our smart air algorithm, enhanced by machine learning, displays continuous information, such as how often do you breathe? How much air do you pull in? If you're starting to struggle because of an obstruction. And this information, the doctors and nurses use to see if you're sliding into a dangerous zone so they can act before your life gets endangered. We know this because we tested it and it works. To date, we have collected airflow data and ultrasound data on sedated and non-sedated human subjects. Our data performs with high accuracy compared to this gold standard spirometry, which is what we use to collect airflow. I wanted to briefly demonstrate a real-life example of an event. Up here, you see the timeline of a patient breathing. The patient breathes, receives the medication. That medicine profoundly affects the patient's breathing to the point that her breathing stops. And once the medication weans off, the patient goes back to breathing normally. Down here, you see our currently used devices that monitor you. And in blue, these blue boxes annotate when those monitors alarm in respect to the timeline when the patient stopped breathing. Look how delayed they are. And look at our airflow data. Just visually alone, you can see that all parameters just flatline, because if you stop breathing, there's no airflow. And once the signal picks up, it's because the patient starts breathing again. Our technology detects respiratory disruption in real time. The respiratory monitoring market is a huge and established market filled with outdated technology. I just wanted to remind you, this is the very market that has gotten us to this situation, with pulse oximetry and capnography performing very poorly in respect to providing quantitative respiratory information, and it is not comprehensive. Yet we're using them as if they were. Airflow is the only technology on the market which will be able to display meaningful, comprehensive, and quantitative data about a patient's breathing. In 2021, the market for pulse oximetry is estimated at $2.2 billion, and capnography is projected to be close to $700 million annually. Anywhere there is pulse oximetry, healthcare providers worry about a patient's heart and lungs, and airflow does have a role. Airflow has the potential to replace the capnography market in non-intubated patients and slowly inch closer to the use cases of the pulse oximetry market. During our National Science Foundation Innovation Discovery interviews, 90% of our interviewees expressed interest in the need in our product. Here are a few testimonies. We heard Dr. Donnelly saying, actionable and quantitative output would be an enormous stride towards patient safety. And we also heard, honestly, anything is better than what we have right now. And Dr. Orhan mentioned, I would have used your device yesterday if I could have objective data to sedate safely. We've done our homework and we do understand the market. As you can see, airflow fits multiple markets inside and outside of the hospital setting. Through our customer discoveries, however, we have identified that the doctors and nurses involved in sedation procedures who are not anesthesiologists fit the entry market best. Those are sedation cases in interventional radiology, in cardiology, in gastroenterology, just to name a few. Their common driver for pain and frustration is that they have a high fear of losing the airway by over-sedating and a low confidence level to rescue the airway if a complication occurs. And more anesthesiologists are administering sedations with lesser training in airway skills in location with lesser resources. We have, once we have our product, our initial small target market will secure collaborations with 10 academic hospitals for outcomes research to identify cost savings and improve end user needs. Publications will be great drivers for adoption. Even though initially we will directly sell to those institutions, we know that a distributor, it will be essential for our scaling strategy. Airflow has done a lot of work. We have filed 4 US patents, 4 international patents. We have received $375,000 in seed funding, showed proof of concept and feasibility in human subjects, and we developed our algorithm. Our current ultrasound machines and probes which we are working with have some limitations for our data collection, signal optimization, and for hands-free probe placement. To eliminate those limitations, in milestone 1, we will develop a form factor fitting ultrasound probe for hands-free continuous data collection and revalidate our data with optimized signaling in human subjects. That will take 18 months. We will aim for an FDA pre-submission for a 510K path with an anticipated clearance in 2024. In milestone 2, we will focus on automation of our software and the development of a freestanding device to be ready for market entry. At market entry, anybody should be able to use this device easily. To accomplish our milestone 1 expeditiously within 18 months, we're seeking a seed round of $1.5 million. Here you can see the breakdown, how the money will be spent, indicated on the right. I'm very proud to have my partners by my side, Dr. Irene Ong, a senior and very accomplished data scientist, machine learning expert, and Dr. Humberto Rosas, a nationally and internationally known clinical ultrasound expert. We do have the drive to move this project to the next phase. It does take a village to make a change. I am inviting you to become that village and start saving lives. Thank you.
Wonderful. We will now start the Q&A. I'm not going to call on the judges, but I'm going to ask if anyone would like to kick it off with the first question.
I'm happy to do so. Um, Dr. Bilen Rosas, that was a beautiful presentation. Thank you so much. What I really liked was the your passion, as well as you really brought us through that in a very compelling way, and really told a story. So thank you for that. My question, actually, I have two, if I could. One is, you talked about adoption via publications, but in terms of just the kind of blocking and tackling, how do you see engaging clinicians in doing so? And is there a separate reimbursement for this item that you know about? How is it going to be paid for?
Yeah, people say the idea is easy, who's going to pay for it, right? So first of all, for the physicians, I am a clinician, practicing clinician myself. So I think one of the most important backbones for adoption is really to understand, what do our clinicians in these various sections of the healthcare system truly need. Somebody in the emergency room may have very, very different needs when it comes to the respiratory evaluation because of the speed and the type of work than somebody who is on the hospital floor on a cancer service. So I think, in terms of, outcomes research, we want to understand, what are their real needs so we can modify, and how are we truly making a difference? We believe we do, but that has to be still proven. And in terms of reimbursement, we do not fit the orphan technology because that's less than 200,000 cases. There's more people having respiratory depression than 200,000 cases a year. What we are looking for and researching is already existing CPT codes, that we can use and piggyback on. We are planning on the application of a breakthrough device designation. However, the CMS just changed their rules for Medicare, Medicaid reimbursement. So the automated payment, is fallen off. But I do believe there's a lot of predicate. There's a lot of there are CPT codes out there that we could potentially use. And outpatient reimbursement is much more lucrative as opposed to the inpatient, because that falls under the DRG code. And so in terms of reimbursement, there's one last thing I wanted to mention is we're bundling pay more and more. And so once the bundled pay really is fully implemented, no matter if you're inpatient and you have these complications, it's still the same pot. The hospital administrators are really having to look very hardly, how are they going to avoid these complications that will eat into their budget, because the budget is not going to grow the pay for their patients.
Thank you.
Jeff, I see that you have your hand raised. Do you want to ask the next question?
Yeah, so there's basically, can you hear me?
Yes.
Yes.
Okay, good. So there's basically two concepts. My first concern would be, thankfully, it's a very small percentage of patients who have these complications where they get overly sedated or they die. So I'm not sure how you could realistically do a study with the endpoint being less deaths or saving lives, just because your cohort would have to be huge. Similarly, I saw you noted SIDS there, which I'm totally in favor of, but would we have to treat every single infant? I mean, you could say, well, we would only look at high risk infants, but as you know, that's a difficult cohort to nail down. So would you have to treat them all? So in order to just kind of give you where I'm going with this, you didn't mention sleep apnea, which, oh my goodness, I can imagine you putting into your device a feedback loop to, I don't know, shock, not really shock, I'm kidding, but to somehow arouse the patient who has sleep apnea when they're having their spell. And then clinically, your endpoints could be decreased sleep apnea episodes. It could be a subjective endpoint of drowsiness during the day. And by the way, that's a huge market. And I can imagine one you could get into. I mean, you didn't present how big is the sleep apnea market, how many people are on, CPAP and all those kind of things. So I'm just wondering, what your endpoint would be to show efficacy, and had you thought about the sleep apnea market?
Yeah, so yes, the sleep apnea market is definitely one of the target markets that we will go after. However, being a clinician in the hospital, in seeing these near misses and the respiratory deterioration. So not every near miss and complication ends in death. For the sake of the pitch, I was trying to show the gravity of it. But how many patients do we have who are actually living at a hypoventilation, basically at a state where they don't get enough oxygen, and then we have 30-day mortalities, and we can't, we just say the patient didn't tolerate that, when in fact there was a significant respiratory component to that. And we are currently unable to annotate these insufficient respiratory periods for various types of cases, whether it's hospital floors, postoperative recovery areas. If you have to perform a chest compressions, that is not documented or tracked unless it is somewhere in a narrative. So, we don't even have a good way of, collecting data for quality improvement, because we don't, the respiratory adequacy is not tracked, because we don't have a quantifiable a device available that quantitates that. So you're right. I don't think my outcomes research is to prevent death, but I think is how fast, it's one of them, but how fast can can we save on medications for a sedation procedure? Do physicians and nurses interact better because there is a communication barrier when the proceduralist says give more medicine, then the nurse worries about, hey, I am at my limit because I'm worried I'm going to lose the airway. How much can we save in terms of these adverse outcomes, because every hospital or recovery room that adds in terms of minutes because of a problem is a cost to not only to the humans but to the institution. And yeah, I haven't talked about the OSA sleep apnea, because that is a very big market and a very different strategy.